Well, today I'm going to talk about the distal hypo-perfusion ischemic syndrome, and that's the preferred term for steel resulting from hemodialysis access. I have no conflicts of interest. So that's, it's abbreviated DHIS, and that is symptoms of arterial steel related to a hemodialysis fistula or graft. And the cause can be high flow through the access, or arterial stenosis, proximal or distal, or diffuse arterial disease, distal to the fistula. And so we're also going to discuss that, and we're going to discuss the diagnosis and treatment of this. So you can see here, you have the subclavian artery, axillary, brachial, radial ulnar, and then, of course, you have the palmar arch. So these are the arteries that are used for fistula creation. This is a distal radiocephalic fistula, so they're taking the cephalic vein and attaching that to the radial artery. Okay, so you have arterial flow that is physiologically, it's intended to essentially creating a steel situation where the flow is going, instead of all to the hand, it is going up through the vein and creating a higher flow arterialization of that vein. And then you have enough flow for a dialysis access. You also have flow continuing to the hand, and if there's not a distal ligation here, you can have some flow coming up through the fistula that is actually recirculating from the hand. And so this is a physiologic shunt or steel that you're setting up. And you can have, near the antecubital fossa, you can use the brachial or the radial artery, attach a graft, loop it around to have outflow within the venous system. And there again, you'll have some flow going to the hand and some flow diverted through this graft. In the upper arm, we're using the brachial artery, and so you can have the cephalic vein attached to the brachial artery, and here you'll have a higher blood flow than down here at this radial artery. You'll have a much higher blood flow. The flow is diverted, and then also you can have the basilic vein. So when I'm talking about the fistulas and the grafts, this is essentially what I'm talking about. But essentially, we are creating a diversion of flow from the artery into the venous system. The vein is a very low pressure system, so the flow is going to be pretty high through there. But it's a physiologic steel that is caused by the creation of the access. Ideally, when you create that, there will be enough flow in the fistula or graft to prevent thrombosis and to maintain an adequate hemodialysis. You're able to clear the blood, you don't get recirculation, the patient gets a good dialysis. But there's still enough arterial flow traveling down the arm to the hand, to the distal part of that limb. Okay, ideally that's what you have. You can have a situation where there's not enough flow going to that limb, and an additional problem could be that there's an arterial stenosis, either proximal or distal to the anastomosis, or you have the diffuse arterial disease. So the prevalence is thought to be 1 to 25%, and in the upper arm, because the brachial artery has so much of a higher flow, it's much more common with the brachial artery accesses. Distal radiocephalic, not so common, maybe 2%. There's more ischemia with the fistula than with the graft. But because you are setting up this shunt, essentially, a lot of patients will have some complaint about ischemia, okay, related to their hand. Usually it's the hand, it can be the feet. So there was one study where they sent a questionnaire out to 120 dialysis patients who were stable, getting their dialysis, and those patients with the brachiocephalic fistula, 79% of them had some complaint of ischemia-related pain, like a cold hand, a numb hand, some sort of pain or discomfort, or maybe a pale hand. With the forearm loop graft, 25%, and with the distal fistula, it was only 12%. So even though it doesn't become something that comes to our attention and that we treat, a lot of these patients are having these symptoms. So the clinical evaluation for this is, you want to get a good history. You want to find out when the access was placed. Did they begin having the pain before the access was placed or after? Is the pain worse with exercise or with hemodialysis? There are risk factors for having this type of pain, and that's diabetes, peripheral vascular disease, tobacco use, coronary artery disease, being a female, and hypercholesterolemia. And it's also important to look at previous radiologic studies, especially any other angiograms or fistulograms that were done, or looking back to the venous mapping when they were before they had their fistula created. Look to see were there any arterial stenoses noted at that time. Physical exam, you want to compare, I'll just assume it's the hand. You will compare the hand that they're complaining about to the other hand, because there are times when you'll look at a hand and it looks kind of dusky and pale, and you look at the other hand and it's exactly the same. Okay, you want to look at the hand, you want to look at the nail beds, you can actually temporarily occlude the fistula or graft and see if that improves the pain. Does it make the color come back a little bit? Does it make the pulse stronger? Try to get an idea of the temperature of the hand. Is it cold? Is it warm? And you can take the blood pressure in both extremities and compare those, see if they're fairly close. You can also check the radial and ulnar pulses. However, especially with the distal radiocephalic fistula, you can have reverse flow from the ulnar side into the radial and feed that fistula. So you may have a pulse even if there is steel. Okay, so it's not completely reliable. And you can look at capillary refill to see if they seem like they're oxygenating adequately. So the symptoms, this has been, there are stages of this, and it's been divided into 4 stages. So stage 1 is a pale hand, maybe a little blue, cold, but no pain, okay? Stage 2 is pain during dialysis or with exercise, and that's pain, cramps, numbness, a coldness in the fingers or in the hand. And 3 is pain at rest or a decreased function of the hand. And 4 is tissue loss, including ulcers, gangrene, or necrosis. Okay? So you want to eliminate other possible causes, when you're working them up, when you're doing your evaluation. So some other things that can cause similar symptoms are carpal tunnel syndrome, ischemic monomelic neuropathy, destructive arthropathy, and peripheral neuropathy, and skin lesions. Also, you can have a hypertensive venous compression that can look like ischemia. So carpal tunnel syndrome, that's median nerve entrapment, and it can be hemodialysis related, that is associated with accumulation of beta-2 microglobulin. It's chronic, and essentially in this distribution here, you will have the numbness, tingling, and pain like that. You can do Phelan's test or Tinel's sign to try to see if that reproduces the pain, and if so, it may be neuropathic. It may not be ischemic at all. You can do a nerve conduction study, and the treatment of this is supportive versus surgery for that. So that's a completely different treatment. Ischemic monomelic neuropathy is an acute development of pain, weakness, paralysis immediately after surgery, immediately during and after surgery. A lot of times there'll be sensory changes, and essentially you'll have a warm hand with the pulse, but the hand will be neurologically compromised. And that is because during surgery, there's been a change to the blood supply to the nerves. So it's ischemic nerves, and it's limited to the nerves. The treatment is immediate access ligation. And most of these cases involve diabetic females, and they really do. They have just a paralysis of that hand. It develops very quickly. So hypertensive venous compression can result from a central stenosis that causes arm edema. The tissue pressure builds up, and it compromises arterial flow, and it can be acute or chronic, and you can diagnose that by history or a fistulogram, and management is to relieve the central stenosis, okay? And usually the radial pulse is diminished. So we can evaluate this ischemia. When we think it's ischemia, we can do an arteriogram. That's the gold standard to diagnose the ischemia. You can do a CT angiogram, MRA. MRA is less, CT angiogram is more common in the lower extremities. MRA is really not a great test to have on end-stage renal disease patients because of the gadolinium exposure and the risk of NSF. You can take a digital blood pressure or use duplex ultrasonography, and you can actually compare the blood pressure in the digit to the brachial blood pressure to get a digital brachial index. And also oxygen saturation can give you a clue as to what's going on. So you want to, when you're doing an arteriogram, you want to evaluate for a stenosis proximal or distal to the anastomosis. You can evaluate flow with the fistula patent and occluded. And then you can do, if possible, you can do an arterial angioplasty to relieve the stenosis and restore flow. So looking here, we have, this is the axillary vein. You have a stenosis there. So this is an angiogram. So you cannulate the fistula retrograde toward the inflow, and then direct the catheter up through the artery, put the tip of the catheter up in the subclavian, shoot some contrast, and you can see a stenosis here. This is looking at a brachiobasilic fistula. Here's a brachial artery. And you can see here you have good flow here through the fistula. There's a stenosis there, but not a lot of flow beyond here, okay? But there's a stenosis there. And then this is looking at a distal radiocephalic fistula. This is the artery, and you can see how it's ragged and diseased here. And then this is the fistula. Now this is looking at this is the artery. That you can see that they've cannulated the fistula here. They have the catheter up and they're looking, and here's a little stenosis, here's a stenosis, here's a stenosis. So that's diffuse disease in this artery. So when that's the case, I mean, if you can angioplasty that'll go a long way toward ameliorating those symptoms of ischemia. So you also want to look at the arterial flow while the fistula's patent. You can see here there's not a lot of flow down here. Okay, so you really want to get an idea. Is there a blockage here, or is it just that most of the flow is going through here? So when you compress the fistula and you do your arteriogram, you can see this artery is open. And looking farther down the forearm, see it's open here? And they have an arrow, it's hard to see, but I think they have an arrow here. So the artery's open, the flow's just not getting down there, okay, because too much flow is going through here. And, and possibly disease. So that's important to remember to do the arteriogram with the fistula open and then with the fistula closed. This is kind of interesting. This is a high bifurcation looking at the axillary artery. Here's the radial artery, the flow coming down here, the ulnar artery, flow coming down here. And then this is the radial artery to which the fistula is attached, okay? There's a stenosis right there near the anastomosis. There's also a juxta-anastomotic stenosis there, okay? And then you follow this flow down the ulnar artery, and you see it's going down the ulnar artery, going across the palmar arch, up the radial artery, and supplying this fistula because of this stenosis right here. So that is steel, and that's causing hypo-perfusion. Okay. And also disease like severe calcification can also limit the blood supply to the hand. So the digital blood pressure, essentially they just put a tiny little cuff on the toe and listen with ultrasound to take the pressure. You know, they're different. There's not a hard and fast rule about what is ischemia or not, but from what I've read, a digital pressure less than 50 is consistent with ischemia. Digital brachial index less than 0.6, or a transcutaneous pulse ox less than 20 to 30. So here's the algorithm that has been published and is widely followed. You have symptoms of hand ischemia. You want to rule out other causes of the hand pain. Perform a complete arteriography from the subclavian. Some people recommend going into the aorta and then do a complete arteriogram of that extremity. If their arterial stenosis is absent, then they may need banding or surgical intervention to decrease the blood supply through that fistula. It's not an arterial supply problem. Okay, if there is an arterial stenosis present and it's amenable to angioplasty, then you should probably go ahead and plasty that. If it's too far central, then you may want to call a vascular surgery. It depends on what you're comfortable doing. If the stenosis is not amenable to angioplasty, then he may need surgical revision. Okay, and looking at the management by the stages that we talked about, essentially a cold, pale, cyanotic hand that's not painful, that's conservative management, as long as the fistula is working properly. The surgery literature divides these stages into 2A and 2B. 2A is where you have pain, but that pain is tolerable. And you have the pain on hemodialysis or with exercise, and that's more of a conservative treatment. Now you can do a fistulogram and do an arteriogram, and if there's a stenosis there, you can open it. Okay, if there's a stenosis, that could alleviate the pain, but you wouldn't necessarily want to surgically revise it or anything like that because the fistula is working and the pain is tolerable. Okay, so 2A is when the pain is intolerable. They're having cramping, paresthesias, and then you will want to do treatment. Okay, you will want to definitely do an arteriogram, open up a stenosis if it's there, and if not, consider surgical treatment, revision. 3 is pain at rest, and that's urgent, and you want to go ahead and treat aggressively. 4A is where you have tissue loss, ulcer, gangrene, some kind of necrosis, but the hand function is maintained, and if you reverse the ischemia, they can recover some function of their hand, okay? And you also want to treat that very aggressively. 4B is irreversible loss of tissue and hand function, and even if you reverse the ischemia, they're not going to regain that tissue again, so that's when the surgeons would need to consider amputation. So treatment can be endovascular, surgical, and there can be banding of the fistula inflow to decrease the flow. These are different surgical procedures we'll talk about, and this is kind of a combination surgical endovascular procedure. So just thinking about the angioplasty, here's our axillary artery stenosis. You go in there, and when you're angioplasting the artery, you do not oversize the balloon. You'll want to, if it's a 6 millimeter artery, you'll want a 6 millimeter balloon. You just put it across there, open it, and he got a pretty good result right there. And looking at our brachiobasilic fistula here is our stenosis, and there's a nice result there, although you still don't see just a lot of contrast going down, but that may alleviate some symptoms of ischemia. These are the different surgical techniques that they have: banding, the drill, Rudy, and pie, and we'll go through these individually. So when you're looking at what type of surgical treatment may be possible, you want to distinguish between a high flow fistula and a normal flow fistula. Okay, so a high flow fistula can have steel just because the flow is high. Okay, the normal flow fistula is, that's very tricky to address those, but essentially you're a lot of times having ischemia because of arterial disease somewhere along that extremity, and very commonly there'll be the distal arteriopathy with calcification or plaques. So if it's high flow, you can band the inflow or do a Miller procedure, which we'll go over, which is a type of banding. And then these are different types of surgical procedures to reestablish flow to the access, but it redirects the inflow so that more arterial flow is going to the hand. So complete ligation is sometimes necessary. You just can't salvage the access. In that case, you lose the access and they'll have to go to a catheter or have the access placed on the other side. Banding involves decreasing the inflow in high flow fistulas or grafts to decrease the flow from the artery, decrease the amount of blood flow that's diverted from the artery. And in doing that, the results from the studies are not good because essentially it's really hard to tell if you've banded enough or if you've banded too much, okay? So you can use intraoperative digital pressures to try to determine, you know, as they're banding, they'll band a little tighter and then they'll check the digital pressure or they'll check the flow in the access and then they'll tighten a little more and they'll check the flow to see if it's still adequate. So if you have a high flow fistula has a flow of 1,500 or more, 1,500 milliliters per minute, okay? So if you're checking the flow and you want to get that down to less than 1,000, you know. So during the procedure, you'll tighten the band and you'll check the flow and try to get it to around that. But the problem is that during the surgery, they may be under anesthesia or getting medications that would otherwise lower their blood pressure, okay? Lower their blood pressure. It might alter the blood pressure readings you get on the finger or it may alter the flow, okay? So this is not as accurate as some of the other procedures. So a Miller procedure is where you cannulate the fistula retrograde, and you want to band this inflow, but you want to size it exactly the size you want it to be. So, and there's a nomogram you can look at based on the diameter of the fistula and the flow in the fistula. It'll tell you what size you want that inflow to be. Say the nomogram tells you you want a 4 millimeter inflow. Well, you get a 4 millimeter angioplasty balloon and you park it right here at the inflow, okay? You make an incision on this side and an incision on this side, and then you gently dissect under the fistula and over the fistula, and you pass a suture under the fistula and then back over the fistula, and you put at least 2 sutures there. You'll use the Proline, okay, a non-absorbable, but you tie it snug against that balloon, and it gives you a good idea. That's the diameter. You know, that's a 4 millimeter lumen in there when you do that, okay? So you'll tie at least 2. I've seen one study they did 6 sutures just to decrease the size of that inflow, okay? And once you have that done, you deflate the balloon and you take it out. And you know, some people will do intraoperative flow, but that way you were limiting the inflow to an exact dimension, okay? And plus it's less invasive. You just have a couple of incisions here, okay? So there was the people who actually put forward this particular procedure kept up with their statistics, and they published in Kidney International 2010 a retrospective review of 183 patients undergoing 225 banding procedures. So complete symptomatic relief was obtained in 89% of the steel patients and 94% of the high flow, which is a pretty good result. The 6-month band patency, 75% in steel, 85% in high flow. And the primary patency was 52% for steel, 63% for high flow, but the secondary patency was 90 and 89%. And that's for 24 months. So that's pretty good. So it reduced that inflow, they got relief of their symptoms, and it lasted for a nice long time, okay? Now, this involved a number of steel patients, and you know, it sounds too good to be true that here you have these fistulas where the flow is not high, and the patients are just having this pain, so you reduce the inflow even further and you know, try to get a relief of symptoms, but they got good results. But this study, I just wanted to show you, this involved 12 patients, 7 high-flow fistulas, 5 with steel, and they did not have a good secondary patency for their steel patients, okay? So working with high flow, the Miller's great. Working with a normal flow with a patient with steel, it's kind of iffy. You might clot that fistula. So one surgical treatment is the drill, that's distal revascularization with interval ligation. And essentially, you know, with steel, you have the arterial flow. Here's the normal. You have arterial flow coming down, but also you have this arterial flow that should be going to the hand. It's coming back up this way, okay? So they want to stop that, so they ligate the artery distal to the anastomosis. So the flow is going here, but then they reperfuse this using kind of a low pressure graft. That's just a piece of graft going from the proximal artery to the distal artery, okay? So the artery, the limb is getting flow here. You've ligated this and the fistula is getting flow, okay? So it improves symptoms in 90% of patients. These are pretty good results with this. It preserves fistula function, and you know, 73 to 100% depending on which study you look at. The negative is that the blood supply to this arm is provided through a graft, and that's kind of iffy. You know, it kind of makes you concerned. And also, when you're trying to anastomose down here, if there's diffuse arterial disease, it's really hard to anastomose that graft. So it might not be the best procedure for someone who has diffuse disease distally. So here's another kind of a modification of that. Instead of ligating the artery here, they ligate the fistula. Then as the artery comes down here, they create an inflow from the distal artery up to the fistula, okay? So you decrease the blood flow to the fistula, you get rid of this retrograde flow into the fistula. And you know, they've gotten some pretty good results with that too. So it creates a bypass to the fistula from the distal forearm artery. And another procedure is the proximal arterial inflow. And essentially they do the same thing. Here's the fistula. They ligate it here to prevent the arterial, you know, the steel, to prevent that retrograde flow. Then instead of coming to the distal artery, they bring the arterial supply from the proximal artery. And then that supplies the fistula. You keep the fistula open. There's a study of 30 fistulas and grafts. The symptom resolution occurred in 84%, and secondary patency at 12 months was 90%. So this is pretty good. And also, you know, even before the surgery takes place, there are some preoperative evaluations you can do. You can to get an understanding of whether or not that patient is at risk for developing ischemia after a hemodialysis access is placed. You can do the Allen test to evaluate the patency of the ulnar artery. You can look at a digital brachial index less than 1 preoperatively can indicate a risk of steel. And venous mapping is a good tool, looking for arterial flow and arterial stenosis. However, it can be that a very small stenosis on venous mapping may ultimately become a stenosis that causes symptoms later on. So even it may look insignificant on the mapping, but it may become consequential later. Okay, so it's hard to know what's going to make you symptomatic or not. So in conclusion, the pathophysiology of distal hypo-perfusion ischemic syndrome involves a combination of physiologic steel, caused by creating the hemodialysis access in the first place, arterial stenosis and distal arteriopathy, and if left untreated, the ischemia can result in debilitating symptoms or even amputations. Thank you. Any questions?
So, with our advancements in understanding of microcirculation and macrocirculation, I am constantly left with the surprise that you can measure things such as flow-mediated vasodilation by duplex ultrasound and get a really good idea of the reserve capacity of vessels and their ability to remodel. We did a study with Hopkins and with Case Western and with Cleveland Clinic, and even in patients that have T2D that don't really have a real impaired FMD, if you follow them out over 6 months, we were stunned to see that their FMD drops in their peripheral circulation without any intervention. So without doing something that looks at, say, the microcirculation of the arterioles, which I could see this being a real problem outside of a physiological steal event. I mean, I can see where you're shunting, and that shunt causes, in all practical purposes, a steal phenomenon in a healthy individual. But when they're sick, how much of this is really being looked at in trying to identify, macrovessel, microvessel dysfunction to see if these patients are going to be at risk for developing this later on?
Well, I don't know if you were here when Dr. Roy Chowdhury was here.
Yeah,
I was. And so I think he's definitely looking into that, and that's a fascinating area that I think is really, a lot of it's unknown to us at this point.
Right. Because we, at least here with the Cardiovascular Center, we now have, on the clinical side, a non-invasive clinical room where you could do arterial telemetry, planar telemetry, coupled with FMD, and I can see where an easy study, very non-invasively, you could identify both the macro and the microvessel reserve in these patients before you do the fistula and see what some of the outcomes would be.
Okay, that sounds great. That's fascinating.
Yeah, no, that'd be great. It'd be a lot of fun.
That would, and this would be, okay, well, that's something that we need to look into.
Okay.
Because I think that's exactly the area, I think that's where it's going right now.
Yeah.
Looking into the micro part of this. Because the macro, is, we know a lot about the macro, but it still is hard to control. It's still, I think it's all the micro. I think you're right. I think that's a great idea. And I'd like to talk to you about that. That's wonderful.
Absolutely.
Yeah. That's good.
How often do you see that you need to have an amputation of these people have a major disability because of the graft?
That is fairly common. That's fairly common. To me, it's common. I would say maybe 2-3 times a year.
And the amputations are just distal or are a little more?
Pretty much distal. Pretty much distal. However, it depends, because once you see that they're ischemic and that you think it's the access causing it, then you want to change the access or ligate the access to prevent the tissue loss. However, we had one patient who refused to let us ligate the access. He said it was tolerable, and his fingers were, falling off. The tips of his fingers were falling off. And the vascular surgeons, really tried to convince him to make a change to that access. If you can catch it in time, certainly if we see any patient with tissue loss on their hands or a cold or a painful hand, then we'll evaluate it. And if you can evaluate it and ligate the access, then hopefully that would preserve the tissue. There's no guarantee, because these are vascular paths, and a lot of times that disease is extensive.
Are there any drugs that have been tried in conjunction with this surgical revision, to see if there's any increased blood flow?
I did not read about any drugs that were being tried. I know that there are very few things will keep an access open. There aren't a lot of drugs that will, that will keep an access open. So, and in conjunction with this, I didn't read of any drug that would do that. Okay, well, thank y'all.